2024 conducted by the College of Specialist Improvement and Rehabilitation. Extremely sorry for delay for 15 minutes. There's a technical issue. So today we have two interesting presentations. First presentation will be on macrophage activation syndrome in children, the silent storm, by Dr. Udari Kulasinghe, Senior Registrar in Rheumatology and Rehabilitation, HLH. Udari.
Thank you, sir, for the kind introduction. Good afternoon to you all. So for the next 30 minutes, I'll be taking you through two interesting case scenarios of macrophage activation syndrome. And on the second part of my presentation, I would be talking about some important facts regarding macrophage activation syndrome. So moving on to our first case, our patient was Master N, a previously healthy 13 years old boy. He presented with a PUO for 1 month duration. It was associated with oral ulcers, lymphadenopathy, skin rash over the face, chest, back, and abdomen. There was no history of joint pains, proximal myopathy, skin thickening, or any other features of vasculitis or connective tissue disease. And there were no other features of systemic infection, malignancy, or endocrinopathy. And there was no significant history of family history or allergy history. Moving on to the examination. He was febrile and ill-looking at the time of the examination, and there were painless oral ulcers over the buccal mucosa and hard palate. And there was a maculopapular skin rash over the face, chest, and abdomen. And there was generalized lymphadenopathy involving cervical, axillary, and inguinal areas. And there was a 2 centimeter hepatomegaly, which was firm and non-tender. Other system examination, including cardiovascular system, respiratory system, nervous system, and musculoskeletal system examination was normal. This was his fever chart from the day of the admission to LRH. And as you can see, it was a non-remittent fever pattern, rarely coming to the baseline. And this was his oral ulcers involving hard palate as well, and the maculopapular skin rash at the time of the admission. So moving on to the keeping these differentials in mind, keeping these clinical findings in mind, moving on to the differential diagnosis, the pediatric team has thought of whether this is an infection, like viral infections like EBV, CMV, HIV, and others, and the bacterial infections like typhus, melioidosis, or brucellosis, as well as tuberculosis, and whether this is an infective endocarditis or autoimmune connective tissue disease like SLE or vasculitis. So keeping these differentials in mind, let's move on to the investigations. So on day 1 of the admission to LRH, his WBC count was 6.3 with a hemoglobin of 11.8 and platelet of 156. His ESR was 30 on admission. And after 5 days, on day 6 of the admission, his WBC was 2.6 and hemoglobin was 10.8 and platelet has dropped to 127. And on day 9, all the cell lines have further dropped, and WBC being 1.9 and hemoglobin being 9.7 and platelet 220. And you can see here on day 9 there's 1 class of albuminuria as well, and the ESR has gone up to 80. On day 14, there was some improvement of all the cell lines, probably because of the commencing treatments. And the other important finding is that there is a nephrotic range proteinuria at day 14. The patient was referred to the rheumatology care on day 22, and at this point, he had a significant drop of all the cell lines, and WBC being 1000, hemoglobin being 8.5, and platelet 218. And you can see here that there is a drastic elevation of the liver functions as well, as AST has gone up to 140 on day 14 to 432 at day 22. And the other important point to note is the ESR, which had been 80 on day 9, has gone down to 67 on day 22 at the time of the referral to 12 on day 24. Apart from that, you can see here that there's a second drop of all the cell lines following the initial improvement on day 14, As you can see, the WBC count was 5.9 on day 14, and there was a drop again when the patient was referring to us, as well as the platelet count. So moving on to the other investigations, that the patient had the history of PUO, his viral screening, including EBV, CMV, HSV, HIV, and the other viral screening was negative. And bilioidosis antibodies, rickettsial antibodies, typhus screening, brucellosis, all were negative. And the TB screening was remained negative. And all the cultures, including 3 blood cultures, urine, and sputum, remained negative. There was a thin rim of pericardial effusion in the 2D echo, and ANA was positive 1 in 100 with a nuclear pattern. As there was a mild hemolysis in the blood picture, we went ahead with a direct antibody test, which was positive for IgG. And his C3 and C4 levels both were low. Apart from that, rheumatoid factor, dsDNA, ENA panel, and ANCA panel was negative. Ultrasound scan chest showed a left mild pleural effusion, and chest X-ray interestingly showed a bibasal reticulonodular formation. Therefore, we went ahead with HRCT, which confirmed the finding of bibasal ground glass appearance. As the patient had a generalized lymphadenopathy, the lymph node biopsy was arranged, which showed necrotizing lymphadenitis suggestive of Kikuchi disease. And the bone marrow showed trilineage hemopoiesis without hemophagocytosis, and there was no malignant infiltration. And as the patient had a nephrotic range proteinuria, renal biopsy was arranged, which showed class 2 lupus nephritis. So altogether, at the time of the referral to the rheumat care, patient was positive for ANA with all these clinical findings, and there was no doubt in the diagnosis of SLE, and patient fulfills all the criteria of EULA 2019 criteria for SLE, and the pediatric team has already came to the diagnosis of systemic lupus erythematosus, lupus nephritis, and rare lung involvement at the time of the referral to rheumatology care. And they have already treated him with IV methylprednisolone pulse therapy, followed by oral prednisolone and HCG. So apart from these findings, what we noted were at the time of the referral were the significant WBC and hemoglobin drop, as well as the platelet drop, as well as the liver function elevation. And the other important point is that all throughout, despite all these treatment, patient had non-remitting fever continuously. And the other important point is this dropping ESR from 80 to 12. So considering these facts, we had the doubt whether this patient is leading to macrophage activation syndrome at the point of the referral. Therefore, we ordered serum ferritin, LDH, and triglyceride. And on day 24, 2 days later, the investigations arrived and the ferritin levels was more than 40,000 with a low fibrinogen level and high triglyceride levels. And the repeat ultrasound scan confirmed hepatosplenomegaly. Therefore, we safely arrived to the diagnosis of macrophage activation syndrome and started on oral cyclosporine on day 24. However, 2 days later, at the illness day 26, patient further deteriorated. There was a new onset mild cough, acute onset SOV with the acute desaturation, and saturation was 89 on room air. And apart from that, there was a macroscopic hematuria following renal biopsy. And the hemoglobin has dropped to 7.4. So this was our patient on day 26, and this was his chest X-ray taken on the same day. Moving on. So what are the differentials in the background of a SLE flare in a patient with acute respiratory distress? As the patient was on multiple immunosuppressants, we thought whether this is an acute infection, but the septic screening was negative, therefore excluded. And we thought whether this is heart failure due to myocarditis, but the normal ejection fraction and the negative troponin I excluded this. And the other two differentials to be considered were acute interstitial pneumonitis or diffuse alveolar hemorrhage. As the patient had a background of interstitial lung disease in the background of SLE, acute interstitial pneumonitis is also should be considered. And apart from that, as there was a significant hemoglobin drop, the diffuse alveolar hemorrhage was also considered. To exclude other bleeding, we did hemolytic screening, but it was negative. And as the patient had a macroscopic hematuria following the renal biopsy, we arranged ultrasound scan KUB to exclude renal origin hemorrhage, but it showed only a small hematoma. So therefore, we went ahead with the CT chest, which showed multiple patchy opacities not confined to any lobar demarcation, together with ground glass opacification. So, moving on the same day, patient then developed a new onset hemoptysis. So, together with these HRCD findings, the hemoglobin drop, developing respiratory acidosis with increased oxygen requirement, we made the clinical diagnosis of diffuse alveolar hemorrhage. So what are the causes for alveolar hemorrhage in the background of SLE? It could be SLE together with pulmonary hemorrhage, and the patient had macrophage activation syndrome as well in the background. So whether this is coagulopathy with mass. So considering both these diagnoses, we started him again on IV methylprednisolone pulse therapy, followed by IV cyclophosphamide pulse. And this was his chest X-ray taken on day 27 of the illness. And this was the chest X-ray on day 28. As you can see here, that despite of the treatment, there is further worsening of the lung shadows. Therefore, on day 29 of the illness, confirming these chest X-ray findings, patient required mechanical ventilation. And after the literature review, we went ahead with IV rituximab 1 dose on day 29. And after combined discussion with the pulmonology team as well, we went ahead with plasma exchange from the following day as every other day basis for 6 cycles. Despite all of these extensive immunosuppressive therapy, patient further deteriorated and increased requirement on ventilator support. Therefore, we started him on IV immunoglobulin from day 31 for 5 doses as every other day basis. So, after 10 days of aggressive immunosuppression, patient clinically improved and the respiratory acidosis disappeared and chest shadows got cleared. And we were able to extubate him. And this was the chest X-ray taken after 10 days of aggressive immunosuppressive therapy. So the clearance of the chest shadows within a week of aggressive immunosuppression further supported our clinical diagnosis of diffuse alveolar hemorrhage. So at this point, patient was on prednisolone 2 mg per kg, cyclosporin 5 mg per kg, and IV cyclophosphamide as well. And we thought the story is the end of the story, but it was not. On illness day 47, 1 week later, patient again developed 2 episodes of seizures and agitated behavior. And there was again rising trend of ferritin from 3,000 to 14,000 with a dropping platelet count from 214 to 132. And again, rising liver functions. So what are the differentials in the background of acute flare of SLE? At this point, patient having a generalized tonic-clonic seizures. We thought whether this is a neuropsychiatric SLE or whether this is, as the patient has a mass in the background, whether this is mass with CNS involvement. So keeping both these differentials, after extensive discussion with the oncology team as well, we decided to go ahead with IV etoposide 120 mg per week. Despite of the first dose of the IV etoposide, patient developed further 2 episodes of generalized tonic-clonic seizures. At that point, patient had severe headache with high blood pressure going beyond 95th centile. So we arranged an urgent MRI brain and it showed press changes. What are the causes for press in the background of a patient who is managing for mass? Whether this is ongoing mass with CNS involvement, or whether this is due to cyclosporin-induced press or hypertensive encephalopathy. So considering both these differentials again, we withheld cyclosporin and decided to continue IV etoposide for the 2 doses. So after extensive therapy, after 2 weeks of this extensive medication, we were able to achieve a complete clinical recovery. And as you can see, the fever was subsiding and the cell counts improved gradually. This was our patient after 2 months of combating against macrophage activation syndrome. And after 2.5 months of hospital stay, patient was discharged and fully recovered without any residual impairment. However, the important point to note is that his ferritin drop was very slow. And at the time of the discharge, the ferritin was 3000. After 4 months, it was 1600. And even after 6 months, it's above 1000 levels. And this is our patient currently, who's an active young gentleman. And that was our success story. So moving on to our second case. Our second patient was a 13-year-old previously healthy girl from Ratnapura. She presented with a PUO for 3 weeks. She had fever with high grade without chills or rigors, and it was associated with a dry cough. On day 3 of fever, patient had bilateral knee joint and right wrist joint pain without early morning stiffness. On day 4, there was a generalized maculopapular rash. However, both these symptoms have been resolved without treatment for the following day prior to seeking medical attention. There were no other features of systemic infection or connective tissue disease. Moving on to the examination, patient was febrile at the time of the examination, but there was no rashes, no lymphadenopathy, hepatosplenomegaly, and the cardiovascular system, respiratory, nervous, and muscular system examination all remained normal. So this was her fever chart from the day of admission, and you can see this is an intermittent fever pattern, and the fever is coming to the baseline at every spike. So to further clarify this presentation, on day 1 to day 6, she had fever, cough with a 1-day history of joint pains and rash. So she was admitted to Teaching Hospital Ratnapura on day 6, and there the chest X-ray revealed some bilateral opacification. Therefore, commenced on IV Comaxcla for 7 days, followed by IV ceftriaxone. But despite of these antibiotics, patient continued to have fever. Therefore, transferred to LRH for further management. So moving on to the investigation from day 21 at the time of the admission to LRH, as you can see on day 21, the WBC was very high, 21,000, with platelet being 468 and hemoglobin 9.4, and her both ESR and CRP were elevated. And after 5 days, the counts more or less remain same. However, if you can note that the platelet has been gone up, there's mild thrombocytosis when compared to normal levels. On day 29, patient was referred to the rheumatology care because of this rapid drop of the cell counts. As you can see, from day 21 to day 29, there's a rapid drop of all the cell lines. And even though the platelet remain normal, there's a slight drop from the initial count, if you can note. And serum ferritin level is elevated, of being 3,758. So to complete the investigations of a PO, we went ahead with all the cultures, TB screening, and the antibody screening with regard to viral and antibacterial, which all remained negative. However, the COVID antibody, IgG, was positive. Apart from that, she had a mild splenomegaly, and chest X-ray again showed by basal opacification, and the 2D echo and transesophageal echo remained normal, and the CSF studies were normal. Her ANA was positive, 1 in 100 with a nuclear pattern. However, the rheumatoid factor, dsDNA, and the C3, C4 levels were negative. The blood picture showed there was no evidence of hemolysis in the blood picture, and the coagulation profile was normal. So keeping all these differentials in mind, on day 29, at the time of the referral to the rheumatology care, we had 2 differentials in mind, as the patient had fever, generalized maculopapular rash, although it was 1 day, whether this is systemic onset JIA or whether this is SLE, as the patient's ANA was positive, combined with the ongoing macrophage activation syndrome. And the second differential, we thought whether this is multisystem inflammatory syndrome in children. Although COVID-19 is rare these days, that the patient has positive COVID antibody and the fever presentation and the rash, these differentials should also be considered. So considering both these differentials, after combined discussion, we went ahead with IVIG, 1 gram per kg, and the bone marrow biopsy was planned for the next day. 2 days later, on day 31, the WBC count was more or less similar, but if you can appreciate, there's a platelet dropped from 424 to 368. Although still remains normal, if you can remember, the patient's initial platelet count was around 500s, and here it has gone down to 368. And the serum ferritin levels was gone up to 9,000. And fever was still continuing despite of IVIG. And patient, however, the important fact to note is that patient was clinically stable despite of any hemodynamical instability, and there was no respiratory symptoms at this point, and there were no organ manifestations. So on day 33, we noted that the WBC counts now dropping with the WBC of 3.9 and platelet 7.7, H being 7.7 and platelet being 191. And at that point, the repeat serum ferritin came as more than 20,000. And the bone marrow biopsy showed hemophagocytosis. So with these clinical findings, we came to the diagnosis of macrophage activation syndrome and started on IV methylprednisolone pulse therapy immediately on the same day, on day 33. However, after 30 minutes of the first dose of the methylprednisolone pulse therapy, patient developed a high-grade fever with chills and a generalized tonic-clonic seizure, 2 episodes, and the urgent NCCT showed massive IVH with a midline shift. The patient was intubated and ventilated and transferred to ICU. And after combined decision with the pediatric neurology team, as well as the general pediatric team, we decided to give on IV etoposide, as well as plasma exchange and IV cyclosporine. However, despite of these combined therapies, patient deteriorated rapidly, and on the subsequent days, patient developed mucosal, subcutaneous, nasal, and GI bleeding. And this was her subcutaneous bleeding, and apart from that, she had melena and ET2 bleeding as well, and AKI with renal shutdown. So on day 38 of the illness, so moving back to the timeline of our second patient, what happened to her? On day 21, as I mentioned earlier, patient was transferred to us, and the pediatric team was changed her antibiotics to IV meropenem while investigating for PUO. And day 29, she was referred to us for the rheumatology team, and we had the suspicion of macrophage activation syndrome at the same day and started on IVIG. But after 4 days, patient, even though we have started IV methylprednisolone pulse therapy, patient developed mass with coagulopathy and succumbed to death. So where did we miss the cytokine storm here? Probably, even though we have started treatment at the first day of the suspicion on day 29, probably the cytokine storm has started to evolve somewhere between day 21 to day 29. So this case highlights the importance of recognizing the onset of macrophage activation syndrome to achieve a treatment goal properly, successfully. So moving on to the second part of my presentation, I will be talking about some important facts about macrophage activation syndrome. So what is macrophage activation syndrome? It is a cytokine storm, a word that we were familiarized during the COVID era. It occurred due to disordered and uncontrolled activation and proliferation of T lymphocytes and macrophages, resulting in increased cytokine production. This results in a multisystemic inflammatory response leading to multi-organ failure. What is MAS and what is HLH? Actually, MAS is a subset of HLH. There are 2 types of HLH, primary HLH, which includes in patients with rare autosomal recessive immune defects in the processing of antigen, which present early in the life. And these patients are unlikely to survive without a hematopoietic stem cell transplantation. And secondary HLH includes usually in older children, and it is associated with triggers like infection, autoimmune conditions, and malignancies. The term MAS is used interchangeably by some as secondary HLH, whereas others reserve it to indicate as hemophagocytosis secondary to underlying autoimmune condition. So term MAS was proposed in 1985 after observing some hemorrhagic syndrome associated with neurological and hepatic derangements in few of the patients. And the important point is that it occurs most frequently in the active underlying disease in the absence of a specific trigger. Epidemiological wise, Systemic onset JIA is considered to be the commonest causative factor among children, followed by SLE and Kawasaki disease. And the other important point is that 50% of the mass develop as the initial manifestation of the underlying rheumatological condition, as seen in our both cases. And the mortality rate is very high, where it can be varying from 5 to 35%. What are the autoimmune diseases associated with mass? As I said earlier, systemic onset JIA, SLE, and Kawasaki disease. And apart from that, inflammatory bowel disease, adult onset Still's disease, which is the commonest cause among adults, and dermatomyositis, enthesitis-related arthritis, and polyarticular JIA. Apart from that, there are case reports with MCTD, APLS, vasculitis, and sarcoidosis involved with macrophage activation syndrome as well. Moving on to the clinical features, fever is thought to be the most commonest finding out of all the macrophage activation syndrome patients, and it is said to be seen among almost all the patients from 95 to 100%, and there can be two patterns of fever, intermittent or remittent. And apart from that, there can be hepatomegaly, splenomegaly, lymphadenopathy, and active arthritis. And the CNS involvement was seen in 35% of patients. And there's an increased risk of developing posterior reversible encephalopathy syndrome PRES in these patients, as we saw in our first patient. And there can be hemorrhagic manifestations in the latter part of the illness due to altered coagulation from liver failure, thrombocytopenia, or platelet function defects. Apart from that, cardiac involvement, lung involvement, and kidney involvement has also been reported, and these are some poor prognostic markers. So moving on to the laboratory features, dropping cell count. Platelet count is the first to drop usually, and the most valuable indicator for differentiating between mass onset and disease flare-up insomnia. As I mentioned, in our second patient, there was an initial thrombocytosis, which has dropped to 300 in the subsequent days. And because of this is because the JIA patients all usually have a thrombocytosis at the first part of their disease presentation. And apart from that, increased ferritin levels, more than 10,000, is highly specific and sensitive to HLH and mass. Elevated liver functions, LDH, low levels of albumin and fibrinogen, and drop in ESR or disproportionation of ESR and CRP are also important laboratory features. The other important point is that hemophagocytosis is seen only in 60% of the patients. Therefore, 40% patients can be negative for bone marrow biopsy, and this does not exclude macrophage activation syndrome. And these immunomarkers, NK cell activation and soluble CD25 elevation, are also reported to be present in this patient. So when should we think of mass? Mass is similar to a disease flare and a systemic infection, so making the diagnosis challenging. Since mass is a subset of HLH, many physicians tend to use HLH 2004 criteria to diagnose mass. But using this criteria may delay further diagnosis of mass. Therefore, in 2016, ACR EULA classification criteria was made, complicating in patients with systemic onset JIA. And this was the criteria. It includes a febrile patient with known or suspected systemic onset JIA is classified as having mass if the following criteria are met, like serum ferritin being more than 684, with two of the following: platelet less than 181, AST more than 48, triglyceride more than 156, and fibrinogen less than 360. Although, so as I said earlier, some physicians still use this HLH criteria to use 2004 criteria to diagnose mass, but it causes further delay in diagnosis. Why did I tell that? Because as you can see here, the cytopenia is noted in HLH 2004 criteria, platelet count is less than 100, and the triglyceride levels are more than 265, and the fibrinogen levels less than 150, which causes, as you can see, the difference between the mass criteria and the HLH criteria. So this may cause a further delay if we wait till the HLH 2004 criteria to be met to diagnose. So Moving on to the more about the diagnostic criteria. These criteria were devised actually to use in clinical trials and unlikely to capture every case of HLH or MAS. And by the time the criteria are available, the patient may be beyond the point of optimal intervention. Therefore, we do not always need to require these diagnostic criteria to initiate treatment. And the best way to early recognition is to look at the relative trend of dropping counts as well as the rise of ferritin. So I would point out some clinical clues to diagnose early diagnosis of MAS. Change of fever pattern in diagnosed case or worsening of fever pattern, new onset rash which is not evanescent, altered sensorium, seizures, renal dysfunction, lung parenchymal infiltrates. These are considered to be clinical clues, although these latter three clues are in the later phases of the MAS. And the laboratory clues are fall in one or all cell lines, which is considered to be the hallmark. And you typically, as I said earlier, platelets tend to fall first. And the hyperferritinemia, more than 10,000, is very sensitive and specific. And fall in ESR, elevated LDH, triglyceride, low levels of fibrinogen, all are markers of MAS. Moving on to the management, the first line therapy is considered as the IV methylprednisolone, followed by oral prednisolone. And IV dexamethasone is considered in some case reports, and cyclosporine is also considered to be first line following the IV methylprednisolone pass. And the second line therapies are IVIG, etoposide, cyclophosphamide, plasma exchange, anti-thymocyte globulin for patients with refractory MAS, and biological agents like IL-6 and IL-1 inhibitor. And out of these, etoposide is considered to be very effective in refractory cases of MAS, and IL-1 inhibitor, although we are in Sri Lanka it's not available, anakinra is an emerging drug to manage macrophage activation syndrome. So before winding up my presentation, I would like to point out some take-home messages for you all. The key in early diagnosis of MAS lies in high index of suspicion, low threshold for complete workup, and doing the full laboratory workup. Hectic fevers, petechial rashes, organomegaly, altered sensorium, encephalopathy often may be the presenting symptoms. And the other important point is that normal marrow does not rule out MAS. Early referral to rheumatology care and management in liaison with the subspecialties are the key to successful outcome. And I would like to thank, finally, I would like to thank Madam Jayathri Jagoda, Consultant Rheumatologist at LRH, and Seguminda Besingha, Consultant Rheumatologist RRH, for teaching me how to sail through this town, and Dr. Rajika Vikramarachi, SR in Rheumatology, for providing me with these pictures, and all the pediatric subspecialties and oncology team, and all the patients and my colleagues for supporting me. Thank you.
Thank you. That's very interesting. I offering two presentations. Now the time for the questions. Okay, yeah. We'll have questions after second presentation. Okay. The second presentation for today is, will be on by the Dr. Jayathri Jagoda, Senior Consultant Rheumatology and Rehabilitation, LRH. And she will be again discussing the same topic, whether it's a storm, triumphs, and disaster, the sharing the experience in the managing difficult cases of macrophage activation syndrome. Over to you, Dr. Jayathri.
So, good afternoon, everybody. This is a topic that is very close to my heart because when I went to LRH, I went there with great fears, though I went for a personal reason, but I was so scared to go there because I knew that children will pursue a lot of things that I'm not used to. So then I faced the macrophage activation syndrome. To tell you, I have worked 9 years out of Colombo. I have not seen a case. I knew the theory of that macrophage activation syndrome can kill, and it's the dreadful, emergency in rheumatology, but I haven't seen that. So what does that tell? So what does that tell you? We fail to recognize the general pediatricians, general, medical consultants, as we all, in general, we are not recognizing this. So that's why we don't see. So after there is elaborate talk, I have actually very little to discuss, but that makes my task easy. I am here to share my experience in this thing. A lot of technical things were talked about by Udari. So opening up, I couldn't help discussing my first case of math. This was an 8-year-old boy whom I will never forget, admitted to LRH from the peripheral hospital with 3 weeks of fever, fluctuating joint pain, lymphadenopathy. And blood picture shows that there was ongoing infection and mild thrombocytopenia, and bone marrow was done, but the report was not there by the time he was referred to us. So this was the initial fever chart at the peripheral hospital, and this was when we saw him first. That was in 2019. So first referred to rheumatologist on the 7th of March. So that was an ill-looking child. So because the bone marrow was also not there, I just started NSAIDs and looked at the last bloods, which was done. This was on the 7th I saw him. Last bloods was on the 1st. And we ordered bloods, full blood count, ESR, CRP, and ferritin at that stage. So, so this was the blood results that was available by that time. That was the first of that month. WBC was 21,000. That is high. So this was the WBC platelets of 521, ESR 135, CRP also, both ESR and CRP were high with high white cell count, high platelets. Ferritin was 570, it's not normal. So I thought I knew my rheumatology and I made a tentative diagnosis of systemic onset AIE. So in children, you especially have to wait for bone marrow before giving steroids, because early arthritis can always be, confused with hematological malignancies, and that was why I could not start anything beyond the, NSAIDs the first day. So then bone marrow excluded malignancy, and by that time my colleague was very sure that there was no infection, though the fever was running high. So all the antibiotics were omitted, fever was continuing. Oral steroids, I wanted to whack it with methylprednisolone. I'm just sharing experience with you. I wanted to whack, but I could not because I was scared. Because there was a pseudomonas isolated from a new lymph node a few days ago. So he was not with antibiotic cover. So I went ahead with oral steroids. So then the same time, chest X-ray showed right side shadows, inflammatory shadows, and 2D echo showed moderate right pleural effusion. We did an echo, right? So the ferritin level was still elevated. So that was, we saw him on Thursday first, and then the Friday where bone marrow came, and the Saturday, because this is meaningless if you don't look at this through the timeline. So 9th was a Saturday morning. We started the oral steroids the day before. Fever was settling, less ill looking, morning review, did not chase the previous day bloods. By noon, my SR was Chamit, by the way. He's a very vigilant young man, very good SR that I had. By noon, he reported WBC has come down to 8.3 from 21.2. ESR is 110 from 135. Could be settling Sogia, as the child was eating well, walked to toilet after a few days. That was the first time he walked after 2-3 days. He was always asking to be taken in the wheelchair. We were discussing the ESR has dropped a bit, so were the WBC, but the child is well. We thought we knew and had control over the situation. So the ferritin levels will be chased because at that time, now actually LRH, at LRH we have a very good laboratory service, but it has the system defects. But you know, Dr. Iresha Jasing from the my Kempat department, she's my colleague, good colleague. She makes sure that now I ask for a ferritin, she provides it the very day, few hours later. So at the time that this happened, it took some time, 2 days for the ferritin to be chased, still being chased, because they collected the samples to run the machine, right? They do it in batches. So Sunday, the child remained fever-free. And then, over the weekend, he remained fever-free. What happened Monday morning when we went? The child has torn a fit. He was bleeding from the tongue bite. GCS has dropped. Unstable BP. Iron drops. ICU. Chased the ferritin that we sent 2 days before. It was 18,000. That is when I saw my first macrophage activation, because I'm just sharing experience because this is important. You can see, you can read 100 papers on macrophage activation. She was beautifully elaborating what is there in the diagnosis criteria and all that. That doesn't mean a thing if you haven't seen. So this shook me. And then he went on to have multi-organ failure and death followed. He bled from all the possible orifices. He even bled through his eyes. Sometime later he batted on like 2 weeks like this. But towards the end of it, I could go and see him in the ICU. I did go. So it was a retrospective diagnosis with macrophage activation syndrome. I want to share this experience with you, even though I tell my SRs, it comes and hits your face, you don't recognize it. So this can happen because when you don't recognize, it's a very confusing situation. It's a PUO, when there's a PUO, there are so many thousand reasons under the sun for a PUO. So it could be sepsis, it could be DIC, the final common pathway looks the same. So we might think that the person died of septic shock or DIC, multi-organ failure, all look alike, but these are salvageable lives if you act in the correct time. So that's why I wanted to talk. We didn't have a speaker. I volunteered to do it because if I did not know it after so many years of being a consultant, I haven't seen this, and all my theory did not help. And this can happen to anybody else. But if I share my experience, it can save more lives. So that's the whole purpose of my talk. My talk is not that technical because Udari didn't leave anything much for me to talk, you see. So if we look at the criteria, look at what happened. This was his ferritin level. When we chart and plot this, you will see that this was the first day, 1st of March. This was 8th of March, but this ferritin didn't come there. By the time we saw, it was here. So this timeline is very important. You have to go out of the way to chase behind the reports. So when you order the bloods, go home, it doesn't count. The full blood count also did not come at the time that we ordered. It came the next day. But we could have detected this big drop here. At that time, I thought the oral prednisolone might have done a trick, done the magic, because the child was fever-free and child was eating well, feeling much better. I thought this drop was due to the treatment, and this drop was because the child was getting better. So, my learning curve, how did I visit? So for the next few months, I got down the BHT, kept it in the cupboard, read every time I can, took back the BHT, and I was asking myself, where could I have detected before this happened? Where did I miss it, and how did I miss it? So, how to diagnose this dreadful scenario before the disaster strikes in a confusing background. So what is macrophage activation? What is HLH? Because every time I read it, I came to a confusion. So Udari addressed some of it. So can the deaths be prevented? I learned, yes, very much. They are preventable deaths, very much preventable deaths. Because for about like last 2 years, 1.5 years, we didn't have deaths at LRH. Unfortunately, the case that represented, it happened one month ago, which again, shook LRH because it couldn't have happened. How best to treat? Because if you see the literature, there are so many regimes, how best to treat it. So I have learned so much through these years. I just want to share these things with you. By no means it's perfect. I'm still learning. Each and every case teaches me more. So do adults get it? Because every time you talk of HLH, macrophage activation, it's always mostly the talk about children. Do the adults get it? Yes, they do. I remember back in, when I was a house officer and a registrar, when the dengue, first outbreaks of dengue came, these people did not know how they died. And a lot of people died until they realized that dengue can cause HLH and leakage and all that. So later we learned very well to manage dengue and dengue HLH. Now those lives are saved. So likewise, we can also save lives if we understand what happens. So it's I don't have to tell this, I'll skip this slide. It's a life-threatening situation. So diagnosis. So when you look at the literature out there, you will find confusing literature. One school of thought looking at it through the eyes of HLH, and the other looking from our end, inflammatory and immune point of view. They are looking at two ends, so they look at they see that difference. So this is happening in management and in diagnosis. This is not my original thought. This was originally shown by in APLA by one of our colleagues in APLA. So I thought it best suits to explain what happens in the within the experts in the world. So Udari showed this beautiful slide again. This again shows there is the world talks of HLH. And there's this primary HLH, which is a very unique entity, that is primary HLH. Unless you do a bone marrow transplant, the HLH can recur and the patients can die if you don't manage that well. I don't know how many of these patients we recognize. We haven't done much at LRH. So that's on one hand, that is primary HLH. But on the other hand, there are so many causes that can trigger HLH, and this macrophage activation syndrome, what we call macrophage activation syndrome, that comes from the rheumatology class. That is, we call it MAS, but clinically, there's not much of a difference in these two, diagnosis or management-wise, if not for the primary HLH itself. So they use many nomenclature, variations. They call it MAS HLH also. So all very similar manifestations. So as Udari pointed out, what are the differences in the criteria? Again, the criteria, if you look at them, they are very loose criteria. See the ferritin more than 684, platelet 181, AST just, above 48, so very loose criteria. So how far can we, and the other hand, they have this, blood and hematology people put out this HLH criteria. They first started it in 1994 and then upgraded it in 2004. And then again, they look at it at 2016 to revise everything. And they describe things about adult disease as well. So again, Udari was discussing this. So I just take your attention. This is our first case, my first death in macrophage activation. So if you know, this is, I have tried to compare the two things, the HLH 2004 criteria and the MAS criteria. This MAS criteria came from, Udari told it, I'm repeating it. This is 2016, they all got together, EULA, ACR, and Printo. All the rheumatology class came together and they are called Printo criteria 2016. So your red figures, show the MAS criteria of 2016, and your yellow cages show the HLH criteria. See the difference. I mean, this is the timeline. Your 1st of March, 8th of March, 10th of March. It goes like that. See, platelet count drops down to, according to MAS criteria, it drops down to significant level to diagnose on the 10th of March. By that time, patient has succumbed to, macrophage activation. His ferritin level, we can't comment because there are 7 days in between the first the blood that we ordered and the last blood that we saw. This is ferritin level 570. It does not fulfill the MAS criteria 2070, but 2016. But we don't know when did this ferritin level went up. But that's happening there, and this is happening 3 days later. Other criteria, they become positive 3 days later. So likewise, if this is yellow cages are the HLH criteria. So see the difference. So this according to that, ferritin level goes up to be significant on the 1st of March, and then the next criteria, that is with available bloods, go up at well after the child completely collapsed here, and then it becomes positive here. So looking at timeline and clinical scenarios, I don't believe much in these diagnostic criteria, and so are the world authorities. So this is again trying to look at the safety with the one Udari prescribed. This again shows the difference in the 2 criteria. So in the timeline, they are so different. So what the world authorities think is, you don't have to depend on the criteria. You got to learn and get it into your system so that you think in the correct scenario. If there's a raging fever, PUO, do a ferritin level. Don't rely on the criteria. Use the criteria as a guideline. But if the ferritin is, with the crazy fever, if the ferritin is high, it is worth considering macrophage activation, because to save a life, you have to hit early. That is a must. Any children who have gone beyond a certain level, I have never been able to retrieve. If they had started bleeding, I have never brought them back. So there's this confusing diagnostic criteria, confusing clinical scenario. So this is not my thoughts. This is missionary and child world literature. Exceedingly high ferritin levels outside the setting of iron overload syndrome should be served as a red flag. Having said that, Raveli is a name that is always, if you read about macrophage activation HLH, you find Raveli's name. Raveli has once suggested diagnosing, starting treatment only looking at the ferritin level. It's that much significant. But then the consensus have not come because there are these things like, iron overload syndromes, and there are other things like, autoinflammatory syndromes where ferritin can go high. But that's significant. So in the correct scenario, you do a ferritin level, then you can, alert yourself very early, right? So the fever pattern, ferritin level, and the trend, follow blood counts and follow the trend. You saw very well in case of my first patient, sorry, I'm going back. So the platelet counts dropping down from 521 to 54. This was where he was 1 day later, he was hit with the macrophage activation syndrome. See, look at the platelet count. It doesn't always come down to the level, right? So therefore, you have to know the criteria, but just don't rely too much on that. So understanding and following the trend of parameters really helpful more than single values. These are not my thoughts, they are in the literature. So you should not wait until the criteria are fulfilled. Have to do the relevant investigations frequently also, because that showed that my first child, very infrequent investigations were done. And in the investigations done in our system needs chasing, active chasing. I have gone out of the way. I have developed relationships with a lot of people. When LRH lab runs out of reagents, I have to rely on RIA lab here. I even had, there was a child in my daughter's class. Her mother was an SR there. I even made a connection to get the ferritin level from her because ours mattered. When I said I developed links, so you have to go out of the way and chase your bloods to save lives. So that saved a few lives. Okay. So place for bone marrow, because a lot of people I have seen they have this mythical belief that bone marrow should be there to, they are so there was the bone marrow was free of macrophages. What did you think of it? Why did you think of it? So Udari answered that question. So it doesn't have to have a bone marrow, right? So this is I have started collecting data, but it's very difficult to analyze after the time is gone. At the acute setting, we are always managing the patients, not thinking of collecting data. So this is very crude data. I have, my SRs have started analyzing. So male-female ratio, that's not very important, but duration of symptoms. So until mass hits, it's like more than 10 days, 41%, 10 to 20 days, 35%, 21 to 30 days, so much of time elapsed is 6%, and then 18% after even a month. So prolonged fevers, we have to be vigilant. So this our cohort again, they had, most of them have all 17 patients, 100% have had fever, lymphadenopathy, rash, hepatomegaly, splenomegaly, active arthritis, some have had uveitis, and also oral ulcers. So that's the observations in our cohort. And how many, 53% had sodium, 35% had other diseases together. I mean, there were kikuchis, there were, viral infections and so on. So SLE makes about 6%, and Kawasaki disease and then 6%. And among these, there were, there are only a few patients there, but I had many other patients. I'll come to that. So this is, the triggers. The world always talks about the triggers. They are said to be viral infections and the disease activity. So we have seen only those, active underlying disease and infection. And the world talks about biologics, triggering mass. We haven't seen any of those cases. At least we haven't used much biologics in our cohort. So the cases I have seen, I had seen Soji, SLE, Kawasaki, BC, and metamyositis together with C viral infections and other probable autoimmune processes. I have seen children who I never came into a conclusive diagnosis because there were kids who had hepatosplenomegaly, huge spleen, huge liver. NA was negative, that was negative. We did not know why it was happening. So there were they didn't respond to antibiotics and they didn't respond to anything much. At the end of it, when the ferritin was rising, we were watching because we did not know the name. We were watching ferritin, and then at the end of it, when the ferritin was rising, we administered steroid. They all settled. So there's a cohort that we don't know what the diagnosis is either. So they are not in that cohort that analyzed by the pie chart. So that's why I mentioned that. So management again the same. Different people will talk of different managements. So this is the 2004 American Society of Hematology. This comes with hemato-oncologists and hematologists. I have been questioned right and left about this regime. The oncology colleagues. I wish an oncologist was here when I talk. Last Friday, I did a talk in LRH. I was not allowed to talk. They are asking me, why are you not following this regime? This goes as a rigid regime of dexamethasone 10 milligrams square meter for the first 2 weeks and gradually coming down. At the same time, starting IV etoposide, and then if not responding, you can add cyclosporine and many other things that they talk in the literature. You can add them, but the DEXA and etopo is going from the beginning. So they argue that because we have had many problematic patients, they are arguing you are not doing the correct, you are not giving treating according to the correct regime. That's why this is happening to you all and all that. They are telling, but this regime is, if you use this unnecessarily, this is a very toxic regime. That demands twice a week IV etoposide. You don't have to do that all the time. I have had kids just ferritin about 20,000 just responding to IV methylprednisolone. You don't have to give etoposide in that case. What you have to know is you have to be familiar with what you can use and use it when you want in the correct time and the correct manner. For that, I'm afraid you need some experience, which I learned in the hard way. That's why I'm sharing this. So this is one of the most very useful regimes. So this is, I told you that they revised this in 2016, and this is what they come up for the plan for adult patients. I'm sorry about this slide. This is a bit crowded, but what it says is you separate out primarily, HLH, and you go for bone marrow transplant. So there are so many secondary varieties, infections, malignancies, autoimmune inflammatory mass, that is mass HLH as they call it, and the drug-induced and other causes. So you treat accordingly. Now, this is more closer to what we do, what I have done, and a lot of other colleagues do, not the rigid HLH regime of 2004 that some of the oncology colleagues are very fond of. So this piece of information comes from our rheumatology plan. This is actually this Samrat Vilayok. He gave a talk. He gave some sessions. I went here at last. So these are kind of they have done a lot of work, and these are the things that they have come up with. The first line is corticosteroids, either methylprednisolone, prednisolone, dexamethasone, cyclosporine. The first line is any type of steroid, and cyclosporine A. So that is how I work. So I start both at the same time, and then if the child is not responding, we can add on. I would add on etoposide or I would try to combine it with plasma exchange depending on the scenario. I'll come to plasma exchange later. So all these things like IVIG, etoposide, cyclophosphamide, plasma exchange. I have no experience on antithymotic globulin. Biological agents, we don't have anakinra, but we have tocilizumab, and even the JAK inhibitors can be used as my colleagues suggest in AMPLA. I haven't read much about JAK inhibitors, but recently we had a child, we are still battling with that child in the ICU because I was communicating with them for another matter. I just asked, they told that JAK inhibitors can be used. So that's a very good thing because it's oral and, available in Sri Lanka. So my experience on glucocorticoids, it's my mainstay of management, IV methylprednisolone, 30 per kg per dose. Maximum I go is 1 gram because when the kids are bigger, when you calculate 30 milligrams, they go beyond 1 gram sometimes. So I stop at 1 gram. So it's changed over to prednisone after 3 days or 5 days. 2 milligrams per kg taken according to the clinical response. So then at the same time I start cyclosporine. It's again 2 to 7 milligrams per kilogram per day. We give it usually 2 divided doses. This comes with 25 milligram capsules, which makes it very difficult to give, tiny children. Sometimes we have to take it out in an insulin syringe and put half of it back and juggle a lot, but it is doable, right? So I keep it around like 5 milligrams per kg. That works very well. So, so the literature says levels should be kept below 200 micrograms, but rheumatology school does not think that even that has to be measured. So caution is hypertension, renal toxicity, because it can precipitate press also that which is present in macrophage activation. So you have to be keeping an eye on the blood pressure. Said to have capacity to switch off macrophage activation. It's a wonder drug because in Soja, I have seen once the accidental discontinuation, human error has discontinued cyclosporine in a child with systemic onset JI months later, presenting it raging fever. So it's a very good drug. So etoposide is the backbone of 2004 regime, and hematology colleagues always rely very much on this. But our literature that is coming from, mass HLH side or rheumatology side, that is, they say it's for non-responders of steroids and cyclosporine. That is how I use it. It's not considered as the first line. It can be given IV, either IV or oral. You saw how it was used in Nadun, and close monitoring of blood counts needed. This is done in close liaison with good oncology colleagues. I mean, I worked very beautifully with Dr. Vasantaratnayaka, so he was very smooth. He would always, look at the bloods and tell me what to give and what to do. He never wanted the child to be taken into cancer hospitals. Some oncologists demand that, but I can't say that they are bad, but they're more confident in giving etoposide there. But there's a danger that they don't understand the underlying autoimmune disease, and 2-3 times children succumb to that also. So I'm very reluctant to send my children away from LRH because other people may not understand the underlying illness. Okay. So etoposide and cyclophosphamide and cyclosporine all can also cause cell drop. So that we come to a time in other that happened. We come to a time if the child is on etoposide and the cyclophosphamide, the cell counts go down to a point while the raging macrophage activity is still ongoing. We can't give those agents anymore. So then you have to know what else to do. Sometimes we had to give once or twice we had to give colony stimulators, but it's not advisable because when the counts drop, you give colony stimulators, you get more macrophages by the colony stimulation also. So then you have to juggle a bit with the existing agents. Then you can use IVIG is a very good addition. So how to use IVIG? It's a very useful agent that can be used on concomitant infection. World literature shows limited data. It just tells you that that's one of the things that it can be used. So my observations are it gives you relatively short-lasting effect. Maybe it buys you time until the blood counts come up and you can give the next etoposide dose. So you can use it when you want, like, you know, in the case of that we cannot exclude infection and so on, we can use that. But always the second case that Udari discussed, she was an IVIG. So I have made my observation. It's not very potent, like, you know, it's not very potent like methylprednisolone or etoposide. But you can juggle it like in Adu's case, where you go to the middle, you have given etoposide, you have given cyclosporine, the counts are dropping, you have nothing to do. Chest infection was concurrently, he was having chest infection. This was only thing that we could use at that time. So have used in settings of suspected sepsis and blood counts too low. Yeah, you can repeat it after 2 weeks. So plasma exchange, this was the biggest tool that I learned how to manipulate. Plasma exchange is invaluable as a lifesaver. So this is also mentioned in world literature as inconsistent results, and it is given in the list of things that you can use. It has a very short-lasting effect, but very quick action. I was happy when the other day one of our colleagues told that his experience in the quickly acting thing. Yes, it's the same experience with me. It's very short-lasting but quick to act. This, you know, the current child that I have, macrophage activation, this child was sent to me by Anushka from Ampara. By the time she came on a Sunday morning, the child was tachycardic. So Anushka told me, warned me that she is impending. If she kept at Ampara, she might not have been able to save. So it was Sunday morning, we came, child was already tachycardic. And then I looked for the ferritin level. The machine was still running and it gave a value of more than 2,000. And then I want we have a very good, backup by our transfusion team. This Dr. Gunaratha will do a plasma exchange for me even in a night. Even on 2 inotropes, he would do it because now we have come together, worked together, and it saves lives. So this girl from Ampara could have succumbed to that in the afternoon if I was trying IVP or anything else. So the machine was running. I warned him that this macrophage the ferritin level did not come to the highest level yet. It is 2,000 at the moment. Please be ready to do a plasma exchange if it is too high. The level came 45 minutes later as 38,000, and he did the plasma exchange the same afternoon. Child came out of base beautifully, and now she succumbed to septic shock, and then she was in the ICU battling for 2 weeks now. I'm in the ICU, but today I heard that he was extubated, so that's good. So broad mass, fourth septic shock came out of it without damaging the major organs. So it's a lifesaver. I know definitely I cannot tell with numbers and so on, but my experience tells if I didn't do it at that time, if Dr. Gunaratha said no to me, that child could have died at the same afternoon. So it's a very quick to act, but it doesn't last. It gives you time to anchor it with something else, right? There are some problems in plasma exchange that which I have noted and happened to me. So this is Hirun. This is he's living now, but one of our children succumbed to this. When the macrophage activation macrophages are high in activity, the storm is in its highest levels. Impending in a few more hours, the child would have collapsed. At that stage, when you try to put the best cap, this could happen. 4 of our children, this happened. So there's bleeding and swelling around the vascular site. This child fortunately saved. All the, my 2 other kids were saved. One child succumbed to the vascular bleeding itself. So that was a bit too late. So they come in the 11th hour. We had to do something. So, but this child was saved. So, cyclophosphamide can address both mass and the underlying disease. So, we use it when in cases of SLE and lung disease and renal disease. Can be used with etoposide. We have combined that. Should be cautious regarding cytopenia. So biologics, there are a lot of biologics that they talk of, anakinra, tocilizumab, and then the newest addition was JAK inhibitors. I did they are talking of other JAK inhibitors in theory. I didn't put them there because they are not very relevant to us. So I was very sad that I did not have anakinra. But I must say that I have learned to save lives without anakinra also. And the world is now talking about biologics precipitating mass as well and biologics masking mass as well. So there are, pros and cons coming up, but the argue is when there is very specifically one cytokine is blocked, that will, prevent the child getting symptoms and fever and other manifestations. So underlying mass is going without us getting, recognizing it. So there's a controversy about this biologic issue, and there are literature about adult mass. They have, separated a column to, identify drug-induced macrophage as well. So it's a and more things. And the consensus now is emerging as inhibiting selected cytokines in a cytokine storm may not be effective. So you try to hit general. So they are not conclusive evidence, but they are talking about it. So this is my cohort of children that I had 17 children looking at, but they have received the cyclosporin, IV methylprednisolone, oral prednisolone, immunoglobulin, plasma exchange, etoposide, NSAIDs, cyclophosphamide. This cohort, only one child has died in this cohort, but I have seen hundreds of other kids, and I even don't remember the counts. But for the last 1.5 years, no kids died. But now again another one died. So this is HLH relapse. This is also I had to learn in the hard way. I had kids, going down beautifully. Actually, this is an exaggerated thing. The fever went down and immediately came up. But there were kids who were okay for weeks. And then again, fever came back. Then when I was not confident enough to put my foot down and tell, hey, look here, this is mass. Initially, I was not. So the pediatricians are telling me this is cannula site, this is an infection, mass was controlled, now this is not coming. So initial stages, we didn't have any facilities to do frequent ferrites. But once one child succumbed because it took 4 days for a ferritin to be sent from the unit. It's not anybody's fault. I'm telling you these things, we need to experience these things. Fever coming for the second time when there was controlled macrophage activation, please always think of macrophage coming back because everything else gives you time. Macrophage activation doesn't give you time. So, do adults get this? Yes, widely recognized in adults now. Treatment recommendations are based on expert opinion plus the other evidence. So, this is basically based on expert opinion. This is something I've worked with oncologists. They think I'm just working on expert opinion and experience, but this is the 2019 journal describes, right? The diagnosis of HLH in adults should be based on the HLH 2004 diagnostic criteria in conjunction with clinical judgment and the patient's history. So it all also takes into clinical judgment into account, right? So challenges, early detection, lack of awareness across the board. One of the reasons that our last patient died was on Sunday, the teams changed and they did not tell me the fever came back because on Saturday when we were going home, that child's fever was nicely controlled, and the next bloods they have the blood counts. I was not informed, but that was not the way I worked. I always call them and ask. By that time, I have been hitting a lot of blind balls, and I thought I look crazy, so I should not because they are in a ward and the other people also can look after. But that caused that death. I can't forgive myself. So timely budgets, and across the board we have to be aware. We have to be mature as teams. teams, as all the multidisciplinary teams, generalists, oncologists, rheumatologists have to work together, and the juniors, the house officers, the registrars and stuff, all of us have to be aware. And there's a lot of unnecessary red tape due drug administration. There's nobody to, dissolve cyclophosphamide. Etoposide can't be given, places other than Maharagama and so on. So this red tape should be, ironed out. I wish that we had a task force on this, because this can salvage lives and people are dying without recognition. So diagnosis and managing underlying conditions is also important, and relapse, the awareness of relapse has to be there. Working with different disciplines, disagreement, difference in experience and opinion, it's both rewarding and challenging. I have learned a lot by arguing with other colleagues, and I have really enjoyed that. It's rewarding and challenging sometimes. For instance, this child who, it took us so much to get an etoposide brought and dissolved and given. But we did it, but didn't work. So valuable lessons that I have learned: early diagnosis, do not wait for criteria, but develop a thorough knowledge about the criteria and pitfalls. You have to learn thoroughly about the criteria and their pitfalls also. Well-looking child might collapse the next hour. So this is one of the other things that we are always looking at the children. The house officer, the registrar was telling me, madam, antima venaka ke baba hundata hittiya. The very last day that the pediatrician was examining, and she was sitting up in the bed and nicely smiling, till the last hour, they will clinically be well. So well-looking child or adult might collapse the next. So don't be afraid to shift between protocols and given to make difficult decisions. Because all give you time, because they all come like in similar scenarios, but they all give you time. Sepsis, our last patient, he went into sepsis and had to be on 3 inotropes 4 days, but she came out of it. But if she collapsed with macrophage activation, it doesn't give you time. So sepsis, malignancy, bad lupus, all give you time, but MAS never does, so act fast. MAS can relapse, be vigilant. One should always liaise well with multidisciplinary colleagues, especially generalists, critical care, oncology, hematology teams. Discussion with an experienced colleague always helps. So experience really matters. So these are my acknowledgements. A lot of people to acknowledge. Thank you for your patient listening.
Thank you, Jayathri. Very informative presentation on macrophage activation syndrome and address how to practically face the patients in our setup. Thank you very much again. And now the forum open for discussion and the questions. The second patient, Udari, is the double quotidian fever. So the typical of JIA. So what happened, that fever pattern after the JIA usually we say double quotidian fever. Then in terms of macrophage activation syndrome, is the same pattern or is it change actually?
Fever spikes were very high, so after the onset of the actually on day 29, we recognized the onset of MAS. And after that, the fever spikes were very high. But before the onset of these generalized chronic seizures, there was a bit fever-free interval as well for about 1 week. And there are certain fever pattern changes that they usually discuss, and I have seen them in my patients as well. The fever stops about the baseline. But this is very subtle.
Yeah.
It's not really reliable. You can't really rely on it, but that happens when you're about the next day, like it stays about.
One patient is a typical double quotidian fever, then at times it become a continuous fever. At that time it turns out the macrophage activation syndrome. Yeah. I have one patient like that. Any other questions? Okay, no question lined up today's program. So we'll be meet on 5th of July. Thank you very much for your participation.